Good evening, everyone, and welcome to the Melanoma Research Foundation's CureOM Initiative Ask the Expert series. We are thrilled to have you join us this evening. My name is Kylie Lapira, CEO of the Melanoma Research Foundation, and we are so excited to have you join us for this wonderful educational opportunity entitled Liver-Directed Therapies for Metastatic Uveal Melanoma. Our mission at the MRF is to eradicate melanoma by accelerating medical research while educating to and advocating for the melanoma community. This November, the MRF engages in a campaign called #IGetDilated. And the purpose of the campaign is to raise awareness about ocular melanoma and eye health and the importance of getting a dilated yearly eye exam. While we know that we cannot prevent ocular melanoma from occurring, we do know that it can be caught early. This month, we hope you will schedule your dilated eye exam and participate in our #IGetDilated campaign to help spread critical awareness. We know that education is critical for patients making informed decisions about their care. We're grateful to TriSalus Life Sciences for their generous support of this webinar series and investment in the MRF's CureOM initiative. TriSalus Life Sciences is an immunotherapy company on a mission to extend and improve the lives of patients with liver and pancreatic tumors. TriSalus shares the MRF's belief that informed patients are empowered patients. Now, a brief medical disclaimer before we get started. We encourage you all to use the Q&A box to ask questions throughout the session, which we will address at the end. However, the information presented during today's session is for educational purposes only, and any individual treatment questions should be directed to your healthcare provider. We also encourage everyone to visit melanoma.org to learn more about the resources we have available for our OM patients and caregivers. Also, this session will be available on demand as part of our online library of resources and shared via social media on the CureOM social media channels. It is now my great pleasure to introduce Dr. Stephen Katz, Chief Medical Officer from TriSalus Life Sciences, to introduce our experts today. Briefly, a moment about Dr. Katz. He joined TriSalus in 2018 as the Chief Medical Officer and Chairman of the Scientific Advisory Boards. In September 2020, he became the Chief Medical Officer. Previously, as a full-time academic surgical oncologist, he developed a reputation as a leader in solid tumor immunotherapy, cellular therapeutics, cancer biology, liver immunology, and execution of immunotherapy clinical trials. His laboratory was focused on studying liver immunosuppressive cells and strategies for enabling immunotherapy in liver tumors. He also currently serves as Associate Professor of Surgery at the Warren Albert Medical School of Brown University. His clinical expertise is in surgical therapy and multidisciplinary management of liver tumors, pancreas tumors, sarcomas, and melanoma. And with that, Dr. Katz, I'm going to pass it over to you to introduce our experts this evening.
Thank you so much, Kylie. We are very fortunate to be joined by two physicians who are leaders in oncology and uveal melanoma care, who will review liver-directed therapies and how they can be used with or in combination with systemic therapies for metastatic uveal patients. Our first speaker is Dr. Sapna Patel. Dr. Patel is an associate professor, fellowship program director, and director of the uveal melanoma program in the Department of Melanoma Oncology at MD Anderson. In her role as a medical oncologist, Dr. Patel is likely the first point of care when a patient is diagnosed with metastatic uveal melanoma. Dr. Patel is also the chair of the SWOG Melanoma Committee. In these roles, she serves as a lead physician for the uveal melanoma trials at MD Anderson, including numerous investigator-initiated and sponsored clinical trials, as well as Project 3 co-leader for the melanoma spore. She is the National Study Chair of SWOG S1801 and S1404, 2 clinical trials, the largest melanoma trials investigating neoadjuvant and adjuvant checkpoint inhibitor therapy for cutaneous melanoma. She's authored over 88 peer-reviewed manuscripts and book chapters, and more than 28 as senior or first author. She's been the recipient of many and numerous grants, including 8 independent intramural and extramural awards from the NIH, NCI, DoD, and other sources as well. The goals of her work are to translate the findings into effective monitoring and therapeutic strategies for patients with different kinds of forms of melanoma. Our other speaker is Dr. Eric Wernberg-Klee. He is an interventional radiologist at Massachusetts General Hospital in Boston, where he is the director of the Center for Image-Guided Cancer Therapy, as well as an assistant professor of radiology at Harvard. He is the primary investigator on multiple investigator-initiated and industry-sponsored clinical trials, evaluating the role of minimally invasive interventional radiology procedures for the treatment of cancer. His lab work is focused on the immune response to local tumor therapies and their synergy with checkpoint inhibitors, and is sponsored by grant funding from the National Cancer Institute. Dr. Patel, would you like to kick us off by providing us with an overview of how you work with patients in determining treatment options, and specifically liver-directed therapies, when they first come to you with metastatic uveal melanoma?
Sure, Stephen. Thank you for that lovely introduction. Apparently we need to trim those down so they're more manageable. So, when a patient comes as metastatic uveal melanoma, I have to sort of do some characterization in my head. And it often boils down to a few things. Where are there metastatic tumors? So most patients will have it involving the liver, but there are a portion of patients who present extrahepatic only. Maybe it's in their bones or in their lungs. And those participants often need, those patients need just a different strategy. If it's not going to the liver, if it doesn't involve the liver, we have to think of often we can't do liver-directed therapies, of course, but we also have to think of a little bit stronger the survival if it doesn't hit the liver first. And then, of course, there's a portion of patients who have both. They have it in their liver and outside the liver. And ultimately, I ask myself the question, is the liver failure, is the liver the most critical organ site? Would liver failure be the outcome that we're trying to avoid? It can be troublesome to have subcutaneous tumors or lymph nodes that you can feel, but it's rare that those cause really a terminal or fatal explosion of tumors. So I really think first of where are there tumors? And when doing that, I also think about what's the size of the tumors. We think of uveal melanoma in terms of the AJCC as a largest tumor burden less than 3 centimeters, 3 to 8 centimeters, or greater than 8 centimeters. And I often keep a ruler or a pair of calipers in my pocket so I can show that to a patient. This is the size of what we think the largest tumor is. When we look at the liver, I also want to know what percentage of the liver is involved. So is it a large dominant tumor taking up a minority of the liver? Or is it a lot of marble or pea-sized tumors taking up the majority radiographically of the liver? Or somewhere in between? And that description of quantity and percent of liver involvement helps me decide, which strategy I need to use, drug therapy, or can we do something liver directed, or would they benefit from both? I also think of their symptoms. Are there any clinical symptoms? Was this metastatic melanoma diagnosed on routine imaging, or did they present after a long period of time or a short period of time to the emergency room or the doctor with some symptoms, and that's how they were diagnosed? Symptoms also come in the form of laboratory studies. So are the lab values that support, say, the liver or kidney function, are those dysregulated? So perhaps somebody feels well, but their liver is showing signs of strain already. So, symptomatology plays a role in my decision-making. These days, with the approval of tebentafusp, I also ask the question, even to our new patient office as they're bringing patients in, do we know this patient's HLA status? Have they been tested? And has it been tested on the blood rather than, say, on the tumor? Has that work already been done, or should we prepare ourselves to order that when they come? So HLA typing obviously now helps to segregate some treatment options. And lastly, one of the factors that kind of gives me some clues is the interval from primary tumor diagnosis to metastatic disease. Is it an interval of essentially less than 5 years, 5 to 10 years? Or is this a case where the tumor stayed dormant for more than 10 years and is emerging after this period of dormancy? I think based on some clinical trial and tumor biology work that we've done, we have some insights of what to do for those tumors that remain dormant. So that's really how I approach a new patient that comes to me with metastatic uveal melanoma. And then I start to think about all these various liver-directed options, of which there are many. And I tend not to pick the exact option. I prefer to do that in consultation with my interventional radiologist, where I know they're considering many of these same factors when determining the optimal liver-directed approach. Might be a good segue now to pass it to Dr. Werenberg-Klee to go over some liver-directed options here, and how you think about tumors that metastasize to the liver.
Wonderful. Thank you for the intro as well, and thank you for the very interesting discussion of how you're thinking about the different the approach to different tumor types, different distributions rather. Let me just share my screen, make sure I'm doing it right. 1 second. Of course, I'm not. Okay, so when an oncologist comes to interventional radiology, and I should mention there are a few other specialists involved, and discusses a patient who might have disease that's metastatic to the liver, we start as interventional radiologists, think of a lot of the same factors, liver, baseline liver function, but what in particular being guiding total disease distribution, how the patient's doing, the tempo of disease. But what I've tried to do in this presentation is actually break it down in just to 2 factors. If we look at, are we looking at a small burden of disease in a sort of an isolated fashion? So let's say a single metastasis to the liver or few metastases to the liver. Okay, or are we looking at a more widespread disease process within the liver? Okay, and there's a lot of caveats involved, but I think this is kind of a good way to bucket it. So what I have here, this picture on the screen is just a picture of a liver here, okay, with a picture of a tumor as well, the tumor being the brown spot, okay? And so when we think about options here, one option is surgery, which it doesn't involve interventional radiology, of course. It involves surgeons like Dr. Katz. And there's certain patients for whom that's the best option, okay? Those are particularly patients who might have an isolated slow-growing metastasis, that might be the right way to go. Okay, and there's a lot of considerations there. I guess I would say, just with broad strokes, you're thinking of the recovery afterwards is maybe one of the guiding factors in terms of when that's appropriate. Okay, so let's say maybe surgery isn't the most appropriate option. Then we start talking about where interventional radiology can come into play. Okay, and one of those is ablation. Okay, so ablation means basically sticking a needle into the tumor under image guidance. So that's under ultrasound or CT guidance. So CT, like a CT scan, we use those for our procedures. And then you either freeze it or you burn it. Okay, so freezing is cryoablation, burning is microwave or radio frequency. And there's a few new flavors of ablation on the block as well. Okay, but these are the dominant ones. And I've actually included a picture to help you understand a little bit better what that means. These are the CT scans. I don't know if any of the participants on the screen have seen maybe their own CT scans, but what we're doing here is this is just an image showing how we're guiding needles into the tumors, and what you can actually see the ice ball during the procedure here. Okay, these are two different examples of patients with tumors in their liver that are getting frozen. Okay, so this procedure is typically a day procedure done with moderate sedation or sometimes with anesthesia, and you would go home afterwards. Okay, and this is a good approach for a single or a few metastases. Okay, I should mention but now moving beyond that to sort of another route would be external beam radiation. Okay, so don't have any pictures of this, but the idea is when you have a single or few metastases that could be radiated from the outside. Okay, so a radiation oncologist might say, prescribe you to have 15 sessions, for example. So you'd come every day for 3 weeks, and you get actually a very brief radiation treatment that can achieve can achieve good local control of a tumor as well. Okay. So then lastly, for a single tumor, you can also consider arterial directed therapies. I'm gonna just not go into, we're gonna discuss this more in a minute in the context of multiple metastases, but the idea being you can actually direct a catheter specifically into the blood supply to a single tumor and give that tumor a very high dose of therapy that can achieve the same effect of all these other things that I've discussed, which is complete treatment of that single tumor. Okay. But when we talk about arterial therapies, really where most arterial therapies are being used is in the context of multiple metastases. So here in this representation, what we're seeing is we have tumors on both sides of the liver. Okay, we divide, an interventional radiologist thinks of your liver in two parts, the right and the left, or it's anatomically divided into two parts, your right and your left. And we often divide our treatments into those two lobes. Okay. And I should mention just everything in this picture is flipped. Okay, this is the way we look at livers. The right side of the liver is actually on the left side of your screen and vice versa. Okay, so to get into those therapies, the idea is arterial therapies. Again, under image guidance, you're directing a catheter into these blood vessels, these are called the hepatic arteries. And you're going to put in a treatment. There's a bunch of different treatments that I'm going to walk you through quickly. They're almost always the approach and the patient experience is very similar, okay, in terms of what the procedure entails. But there are some important differences we should discuss. Okay, so what I've included here are just a few pictures that kind of give you a sense of what that means. This is what your interventional radiologist is looking at when they're looking at talking about any sort of arterial therapy. So these are various pictures of patients' arterial anatomy, their hepatic arteries with small catheters in them that are releasing contrast, the same sort of contrast you might get for a CT scan, and showing different distributions of tumor. Sort of the dark spots you see are tumors. And the picture on the upper left is an example of a patient with just very small localized disease that actually might be a good candidate for the very focal ablative treatment with arterial therapy I've actually discussed as well. So to talk about those different flavors, okay, and there's a lot of different flavors that are being used at different institutions for the treatment of ocular melanoma, and not every institution is actually going to be doing all of these, and at our institution, we don't do all of them, okay. So what Y90, which you also hear termed as radioembolization or TARE or CERT, all those different terms are the same thing. But the idea is when you get those catheters out, you're going to be delivering radiation, little beads with radiation on them, a radiation called yttrium-90. Okay, and there's a couple different flavors of those. And what that procedure typically entails is two different and sometimes 3 different visits. So a mapping procedure, and then a visit about a week later to get treatment of part of your liver, and then visit about a month after that for another side. And some institutions will combine that into a single visit. And then also there's chemoembolization. Same idea. You're taking there's these little beads that have chemotherapy embedded in them. So doxorubicin is typical. Some institutions will instead actually do chemotherapy mixed with an iodized oil. So it's called ilopiridol, and they deliver that. That therapy is typically, again, you don't need a mapping procedure, can be a little more painful up front, and patients may stay in the hospital overnight for pain control, okay? But also has been demonstrated to be effective, okay? Then there's also bland embolization. So bland embolization is a term that just means basically choking off the blood supply to these tumors. A lot of tumors are growing because they can pull this blood supply from the liver, and they use all the nutrients in the blood to grow and grow and grow. If you can choke that off, you can suppress their growth. And so bland embolization can be you taking those same little beads and just really blocking off the blood supply, okay? And then a variant of that is immunoembolization. Immunoembolization is where bland embolization is being combined with infusions of GM-CSF, which is a molecule that basically promotes an immune response within the tumors. Okay, so all of these have some data to support them in terms of their efficacy, and really when we look at them, a lot of the data that exists suggests that many of them are sort of equivalently efficacious. And so a lot of the way it will be approached is going to be in terms of what your institution really does the most, maybe for the treatment of ocular melanoma, but also just institutional expertise, and also how to layer them. So it's often at least in our practice, what we'll be doing is combining these together. So for example, we may start with radioembolization, which doesn't block off the blood supply as much, and then down the line do another therapy that actually has more of an embolic effect. As saying after that, once you've embolized, it's harder to, basically saying that the flip of that would be challenging just technically, because once you've already blocked off the blood supply, it's hard to get radiation into those tumors, okay? And then what I should talk about are a couple new therapies on the block for the treatment of ocular melanoma, which are both very interesting. One of them is a melphalan infusion. So melphalan infusion actually been around for a while, but is in different sort of variations, but is still technically investigational. And what that is infusion of a chemotherapy called melphalan in a procedure. The drug is infused in an arterial infusion similar to the other procedures that I've discussed, but there's a filtration system that basically prevents the melphalan from getting out of your liver in high quantities. That is actually a very involved procedure itself to do that filtration. But the filtration is supposed to prevent the myelosuppression. So basically avoid damage to your bone marrow, which can be seen if you just get systemic melphalan. And then another investigational arterial therapy, and I should mention, sorry, that's currently at both Moffitt and Duke. And then another arterial therapy that's also investigational, active at MGH and at MD Anderson, among others. And I just went from northeast to southwest in terms of my list here for the active sites. But what that is, SD101 is a TLR agonist. So that promotes a portion of your immune response called your innate immune response. And that is done in combination with checkpoint inhibition, so PD-1 inhibition and CTLA-4 inhibition, to really try to alter the immune environment within your liver to recognize tumors and create maximum activity against them. So I think that is the end of my whirlwind tour through arterial therapies here. So I will stop sharing as well.
So what I find fascinating when it comes to, patients with metastatic uveal melanoma, there's no one right answer. There's no one, answer for everybody. You have to do this first. You have to do this second. I think we certainly take it as a judgment based on how the patients are presenting and what we have available at our institution. There are some other liver-directed options that maybe some of the attendees have heard about, things like intrahepatic infusion or perfusions, I should say. I think we call that IHP, and then percutaneous hepatic perfusions. I don't know, Eric, if that's something that you do. We don't really do that much at MD Anderson. It's quite technical. It really involves the expertise of strong interventional radiologists, but a lot of support staff too. We have to have perfusionists on staff and like anesthetic teams to monitor for blood pressure things. Is that anything that you typically do, IHP or PHP?
Yeah, so no, we're not. I mean, I guess I alluded to it with the melphalan infusion, right?
Yeah.
So that's those are being done, in concert with the isolation of the hepatic veins, right? It involves the perfusionist, cardiac anesthesia, quite involved procedure.
Yeah.
And so, I think as we've actually discussed before, yeah, the team that's needed to do that correctly, we just haven't built that, at our center. And I'm the institutions that have, that's wonderful. That's really great that it's an option. It is something that requires a huge commitment on the institution that's been hasn't worked yet for everyone.
Yeah, it's not scalable for a lot of places. In Europe, actually in the UK, Southampton was one of the sites that did a lot of the PHP melphalan. In the US, the options would be Moffitt Cancer Center. I mean, they do really quite a bit of this PHP with melphalan, and Thomas Jefferson University is skilled at this, but you are going to have a hard time finding it, highly accessible. In Europe, they also did a trial called the Scandium 2 trial, where they they're doing it now, where they're combining intrahepatic perfusion with systemic therapy. And like you were mentioning with the Tricella study, this is where we think there's a power in doing liver-directed plus some systemic therapy. Another thing that we often engage our interventional radiologists for help with is sometimes oncolytic or intralesional therapy. And so there are some clinical trials. There's a trial using an agent called PV10 from a company called Provectus Biopharmaceuticals. And that's intralesional therapy in the liver. And there are some really strong metabolic complete responses or partial responses that we're seeing on PET scans for those. And we're kind of doing a deep dive to see what's happening at the tumor and in bystander tumors. But that trial is really unique because unlike a lot of clinical trials, this one actually allows you to take systemic therapy alongside their clinical trial agent. And I'm just going to share a slide here. When you think of standard of care systemic drugs, medicine, drugs that we give you into your bloodstream or pills that you might swallow, there's not that many standard of care agents available for metastatic uveal melanoma. They really all fall under the category of immunotherapy. And we think of drugs like Keytruda or Opdivo, the Coke and Pepsi, if you will, of anti-PD-1 therapy. Yervoy, there's a new drug, Opdualag, which is a combination of LAG-3 plus Opdivo. And then, of course, tebentafusp, Kimtrac is the brand name there. It's a little more difficult given the weekly schedule, but these drugs can be combined with liver-directed therapy. I would caution, though, that there can be insurance implications, because if insurance is holding an authorization for something like Y90, say, and then the medical team comes through and says, hey, give me approval for weekly Kimtrac, tebentafusp, it could be problematic. The insurance will often say, which of these treatments are you doing? You have to pick one. It's not common that insurance will authorize two different or unrelated or unproven treatments to be given together. So that's often where we run into issues. But with drugs like Keytruda, Opdivo, Yervoy, Opdualag, or even Opdivo plus Yervoy, because they're given at different intervals, longer intervals, say every 3 or 4 weeks, you can often slide in there with an authorization for a liver-directed therapy, an ablation, an embolization, a radioembolization. And oftentimes, the insurance thinks you've just stopped one of the treatments and resumed another. So there are ways to do that, but outside of a clinical trial, it's often very difficult to combine liver-directed therapy. And that's really because, that clinical trial agent or device in some situations is really trying to identify if their investigational agent or device is doing the heavy lifting. So how can they tell if you're also combining that with liver-directed? We don't often care from a patient or provider standpoint. We just want the best outcome. But from a clinical trial sponsor standpoint, they would have a hard time knowing if the results were from the the systemic therapy or the liver directed. But the Provectus trial, the Trisalis trial, Scandium 2, these are all trials that either allow or were designed specifically to combine liver directed therapy with systemic therapy. And in uveal melanoma, it will take some combination of that. It's very unlikely that a single drug or a single maneuver will take care of what we know is typically widespread disease that's in the circulation. So some combination of treating the liver, but also treating the bloodstream is ideal. Eric, I wonder if you know about this trial called the SIRTAC trial. This was also done in Europe. This was a trial comparing two different types of liver directed. It was SIRS or Y90, yttrium-90 radioembolization versus chemoembolization, but with what they use in Europe. So a cisplatin-based chemotherapy and a degradable starch compound. So when they combined liver-directed A versus liver-directed B, Y90 versus chemoembolization, the response rates were pretty similar. It's pretty difficult to generate a global response in the body to these liver-directed therapies. It was about 5% each, but the progression-free survival was notably longer in the group that got the Y90. So it went from a couple of months in patients who didn't get Y90, or I should say in the chemoembolization arm, to about 5 months in those who took Y90. And if you just looked at how the liver was doing with these liver-directed therapies, it was a couple of months progression in chemoembolization compared to about 8 months with Y90. And I don't know if that tracks with your clinical experience, that Y90 might give you a longer sort of runway in between treatments. Chemoembolization may be shorter, and maybe you stack those together more multiple treatments together. What's your take on those two?
Yeah, I mean, I think that also tracks with the literature that's been emerging on Y90 versus chemoembolization and other malignancies as well, where this comparison is being looked at sort of across the board, and we are seeing better outcomes in general with Y90 than we are with TACE. Yeah, of course, we're talking about different flavors in all of these different situations. But we think of the radiation has a therapeutic effect over that is a little larger per bead, for example, than the chemo. So you are more likely to get more complete treatment.
Okay. I've had, I changed my thinking with Y90 over the years. I used to think because the beads were so small and the beads could really get into that capillary system so nicely. My thinking was, okay, it's for tumors that are really widespread. And so small tumors and small blood vessels get this there. The beads can kind of go throughout the liver and treat those little guys. And I had a case of a specific patient who had a really large, I want to say it was 8 centimeters or so, banging on the other side of 8 centimeters, probably closer to 9, pretty dominant liver metastasis, not a whole lot of smaller tumors. And our interventional radiology group dosed that tumor. So now they were able to give this one tumor all the beads instead of, the whole right lobe or the whole liver, all these beads. And this was an outstanding response. We treated this gentleman in February, just before the pandemic shut down. There couldn't have been a more optimal treatment because, as you know, Y90, you're kind of done until you have progression. So more than a year went by. It was a year and a half. And this thing went down to about 2 centimeters. In fact, he has a goiter in his neck that's bigger than the size of his, how small his tumor got. So he got this nice kind of golf ball sized tumor in the liver from a bigger kind of grapefruit sized tumor. And then it started growing again. It started growing to 3 centimeters, 4 centimeters. So we did it again. We did another Y90 about a year and a half later, got another outstanding response. And that's now been, we might be already, we're past a year now from that second Y90, and he's doing really well. I saw him probably 6 weeks ago. So it's really changed my thinking. Now when I see dominant tumors, large dominant, I think, and this is probably how you've always been thinking, and the radiation therapist, I'm going to dose that. I'm going to be able to give that big tumor a lot of these beads and dose it. And that really helped me reframe that the small miliary disease, maybe Y90 isn't the thing for that. I don't know if you have a different approach when you see miliary disease in the liver, a lot of small tumors throughout the liver.
Yeah, I think you bring up two interesting points that are, I guess I am kind of tooting this horn a lot within our internal tumor boards as well. But yeah, the approach called radiation segmentectomy basically is what they have done. That might, it's referred to that way as well, where you can with Y90 deliver what are massive doses to a solitary or a small area of your tumor in actually a very, very safe fashion for the patient, because you're leaving the rest of the liver alone.
Right.
And so that's been actually, that's again, a lot of Y90 experience is also in other tumors, but that is becoming a dominant mode of treatment in some other tumor types, and in ocular melanoma, in the right patient who's not going to be getting disease elsewhere in their liver. I think that's really a good way to go. With the miliary disease you mentioned, I do think that's something you have to think about more in terms of, that does require something that gets sort of everywhere, right? You need to treat everything there.
Yeah.
Y90 can have limits in terms of, because you just can't radiate the whole liver that much without having toxicity, and you need to be really mindful of that in your choices. So you do have a sort of a limit to how many beads can be distributed. In that case, I've certainly Y90 can be beneficial. But yeah, I would agree with you that those patients are more often going to need other therapies more quickly.
Yeah.
And some of that might refer to the treatment, and some of that I think might refer to sort of tempo of disease.
Yeah.
When you're looking at that disease distribution.
Yeah. I do see a question here from the audience, from John. Hi, John, out there in the world. It's nice to see your name up here. So the question is, Dr. Patel, you mentioned a possible different treatment plan for patients presenting with Mets 10 years after primary. Can you expound on that? Would the treatment be less aggressive? It's a super question, John, and it's really just, tincture of time that I've learned this. So I ran a clinical trial for the US. It was called CA 184187. It was using two immunotherapy drugs, Opdivo and Yervoy, kind of the standard melanoma regimen that had been approved for skin melanoma, but had never proven itself for metastatic uveal melanoma. So we gave the standard 4 doses of the combined drugs and then went on to Opdivo maintenance every 2 weeks, which is now changed into a once a month regimen. And interesting, some of our strongest responses was somebody who had more than 25 or so years emerge from the primary eye tumor. She was in college at the time and then in her 40s when it emerged. And so, I started to think, is that interval telling me that when it emerged, the thing that held it dormant, was it the immune system? And then we can give immunotherapy to those patients. So of course, as I saw these patients come through, I really tried to earmark them for this treatment. Another patient came through and also had quite a long interval, more than 10 years, and did pretty well on the treatment, did not go into a complete response, but really did have stabilization of tumors. And then another patient came and really with probably a 13-year interval, and it just didn't work. Her tumors just grew right through it. So that's a little bit of Goldilocks. You get kind of different responses for each one of those, but broad strokes for people who have a long interval, I do see a few things. Sometimes it doesn't go to the liver first. If it does go to the liver, it's not this diffuse or multiple tumors, spreading everywhere. Although, that first patient who had a 25-year interval had 5 lemon-sized tumors in the liver. So it wasn't small disease by any means. But I do think there is something, the immune system is telling me something if it's managed to stay dormant. There may also be a gene that actually predicts for these late metastasizers. It's a gene called SF3B1, a splicing factor gene. And when it's mutated in uveal melanoma, those metastases might be coming, but they're not coming immediately. They're often later, so past the 5, 7, sometimes even 10-year mark. And those participants, if you look across a lot of trials, I think if the Immunocore team that I see on the call here, if they looked at their KIMTRAC data, if they know the SF3B1, they might see that those participants perhaps are having a stronger benefit. And I think we see that in our Yervoy Opdivo trial and some other treatments. So that interval to me often tells me some things that I need to know about the, presumed immune system that the patient might be having. So I hope that helped answer it. I do have a question for Stephen, and I don't know, Stephen, if you're considered a panelist with us or not, but I had maybe a question for Stephen and Eric about the liver. When we look at the liver, we don't send a lot of patients to surgery with metastatic uveal melanoma. There is European data that suggests even tumor debulking. And by the way, here's the reason we don't do it, because typically you can't render somebody disease-free with surgery. It's not just one tumor. Even if radiographically it looks like it is, it's not. When you get in there and open them up, you can visually see far more than the radiology can pick up. But in Europe, they found even when you open somebody up and say, gosh, there's more tumor here than I would have guessed based on the MRI or ultrasound, debulking those tumors does extend survival. And that's in the face of, drugs that had not been historically very effective for this disease, chemotherapy, et cetera. I wonder, Eric, when you go in, so as an interventional radiologist, you essentially have a lot of times a camera that's going in that you can see the liver. Do you often get a sense of the surface of the liver or other kind of what's happening in other lobes that radiographically may be underreported?
It's an interesting question. Not on the surface of the liver, we do not, but we do. There's something that we do sort of it's a routine aspect of certainly any mapping procedure prior to a Y90, where that's called different things at different places, but we call it a Dyna-CT. It's a cone beam CT. I think you guys call it a fan beam. Have a fan beam CT at MD Anderson, but where you're doing constant injection of contrast and getting acquiring a three-dimensional image. And we do often appreciate that the burden of disease is actually far more extensive than even an MRI, would suggest. So even maybe the DWI sequence would suggest. So yeah, no, it's not uncommon. I would agree that the burden of disease in reality seems to be different and often more extensive than it would be suggested on the imaging. Yeah.
And that's why we sometimes, we put stock in our radiology reports, but we are searching constantly for other tools. Is there another marker of response? Is there necrosis on a scan? Is there, with some of these treatments that we're doing, we are seeing kind of change in the radiomic features or some of the measurable features on a scan, not just black and white. What is the size of these tumors? And we're also investigating things like liquid biopsy. So will some blood shedding from the tumor, will some of that DNA actually track better how the disease is doing in the liver, knowing that the radiology kind of underestimates it?
And that's with the Immunocore, right? In particular, the CT, following the ctDNA.
Yeah, they've certainly published on that. We're doing it alongside many other trials, along the Trisalis trial, the Provectus trials. I think we're looking to see, can we reproduce what Immunocore did? Is there a blood marker, a series of markers in the blood that might actually tell you who's going to have the real survival from this treatment, even if the radiology doesn't demonstrate true shrinkage? So I think that's important in this disease. So.
Well, Dr. Patel and Dr. Berkeley, thank you so much. And I want to continue to encourage people to put questions in the Q&A box. We have a couple questions from patients that they sent in advance of the webinar. And Dr. Patel, you touched on it a little bit, but for patients who are being treated in the community setting, so they're not going to MD Anderson, they're not going to MGH, how do they advocate for liver-directed therapies to happen with systemic therapies? You mentioned insurance kind of being a hurdle, but what are the things that patients need to do to advocate for themselves?
Oh gosh, I mean, I'll start, but I think this might also be a question for Eric. The fact being that depends on who they're seeing, right? So if they're in the medical oncologist office and the medical oncologist is talking about drugs, but not really engaging about something specific for the liver, it's a simple question like that. Is there anything we can do targeting directly for my liver. And that might just cause a light bulb for the oncologist to say, oh, well, maybe I should engage with my interventional radiologist. Because I couldn't make the decision yes or no about a specific liver directed. There's a lot of anatomical blood supply, lobes of the liver, things like that interventional radiology needs to review and sometimes do some of these planning scans before they know if a treatment is viable. But I think it's reasonable to ask. I don't know, Eric, do you ever see patients who come the other direction, who end up, there's a referral to you for some procedure or biopsy or something, and then you say, well, we can actually, talk to the medical oncologist and do some combined approach here?
For sure. Yeah, I mean, I think, I guess there's two questions here is, how can you maybe get more liver-directed therapy in there, but then also the idea of how can we be doing more of both at the same time? If you're getting systemic therapy and not getting liver-directed therapy, ideas coming from the oncologist and the interventional radiologist, let's say. Well, if it's just your oncologist who's not thinking about it, I think advocating for referral to an IR is worth thinking about, or just the concept of, can we do something directed at my liver? And I know the ocular melanoma community in general is very well informed and seems to be very good at advocating for themselves. But it may take quite a bit of that, because your interventional radiologist may not actually be all that familiar with the role of interventional radiology in the treatment of ocular melanoma, just because it's an uncommon tumor, and it's not necessarily just as it may not be the part of every oncologist practice in the community, it's also therefore not going to be part of every interventional radiologist practice too, which isn't to say that they can't do an excellent job for you. It's just, they just need to be, help them to know what they can do in a way. But yeah, if there's patients who, I think, trying to just have a two-way channel of communication, back and forth all the time. There's more and more data out there now suggesting the safety of these combination approaches. I guess our group has published on just that experience overall of combining immunotherapy with local regional therapies. MD Anderson has published quite a bit on that as well. And the idea that really the toxicity profiles seem very, it is not toxic to add local regional therapy on top of systemic therapies. There are open trials that are looking at this as well, and so there has to be some caveats to this. I'm just saying, based on our experience at least, the combination can be quite well tolerated, and I think is in patients' interest.
So that's a good point. It kind of leads me into the next question about the order of treatments, because, we talked about patients seeing you first versus patients seeing Dr. Patel first. So how does the order of which you receive treatments impact your eligibility for future treatments or future trials? Do patients need to take certain things into consideration and say, well, I don't want to do this first because then I might not be able to do X down the line? What does that thought process look like?
Yeah, I'll take this one. Let me take it from just a realistic standpoint and then just a biology standpoint. So realistically, there are, we have a few standard of care drugs, and we have some liver directed therapies, and in a great situation, we can combine them, but it's not a never ending, a list of options. So ultimately, a clinical trial is probably going to be discussed at a center like MGH or at MD Anderson, or even in the community after trying a standard maneuver, either with liver directed or immunotherapy. Assuming that a patient is still fit and willing, then the discussion about a clinical trial will come up. So clinical trials, by and large, have certain eligibility criteria. And there are certain trials that really want an untreated patient. There's not very many of them. There are trials that will say, we'll take somebody who's had liver directed, we just don't want them to have had any drug therapy. So there's those types of things. In that case, things like Y90, bland embolization ablations, those kinds of things could be an option. But there are some trials that will say we really just want a totally untreated patient. And that's because often you're starting, with the lowest volume of disease at that point. And so whatever you're testing might have the best chance of working. So that's something to consider just realistically. Do we have one shot on goal, or are we going to take multiple shots on goal? And if we're going to take multiple, how do we sequence this? From a standpoint of combining liver-directed with systemic, there is some biology here. I mean, liver-directed cannot help you with the lung metastasis, and it can't help you with the bone tumor and the lymph nodes. And the systemic therapy that we use, the Yervoys and Keytrudas, are not that strong. So they're not really wiping out a lot of disease. So what we're really trying to do is get that liver-directed therapy to start the dominoes falling on your immune system, to do something to sort of, we call it technically present antigen to your immune system. I equate this to sort of cracking an egg open so you can see the yolk. We want to do something, whether that's radiation ablation, Y90, embolization, intratumoral, intralesional therapy, hepatic infusion of something. We want to do something to crack that egg open. And now your immune system will say, oh, I've got a cracked egg over here. I've got some spilled egg. I got to go clean up. In no way does that spread the tumor, though. Nothing about antigen presentation spreads the cancer. It just helps the immune system that's with every heartbeat passing by see the cancer. So for me, I like the idea of starting with liver-directed first and then giving the systemic therapy. Realistically, a lot of our systemic therapy stays in the blood system for 3 weeks or so. And so 100 days truly, but it degrades by half in 3 weeks. And so you could start with the systemic therapy and then do the liver directed. But what you could have happen is that immune system gets distracted and goes off and causes some side effect in the intestines or in the liver before you get a chance at the liver directed. So for me, I don't know, Eric, if you feel that same way. I like the idea of starting with liver directed. So a radiofrequency ablation, following it with Keytruda, or a liver directed A or B, and then following it with some immunotherapy.
No, and that's sort of exactly how to get that recipe right, if you will, is I think like one of the critical questions that we're all engaged in. And I tend to agree with you that you need to have those antigens there, right? You need to have somehow perturbed and exposed that tumor to the immune system. And whether it's having a single dose on board prior to initiation or doing it immediately after to maybe prevent, a rebound tolerogenic effect after this immune stimulus is a little unclear. I think the practice pattern that or the way I often see patients after they've already had some immunotherapy. So it is, I guess, yes, I think patients should be coming earlier to get liver-directed therapies. But I guess in practice, what we're seeing now is immunotherapy as sort of a first pass. And as you had sort of mentioned, I mean, the normal oncologist bias, I mean, your toolkit is systemic therapies. So
yeah,
you can offer what you have, as opposed to, oh, you just showed up to the oncologist. Now let me refer you away to somebody else. So I think that may be more of a dominant practice pattern, is to say, we're going to give some sort of immunotherapy up front, some combination of thereof, and hopefully we get some control. And when if we don't, refer to liver, and at that time maybe combine. But yeah, I'm not exactly. I don't think any of us are exactly sure what's going to be the most efficacious. But I kind of tend to share your bias that in some antigen presentation as early as possible is a good idea.
I wonder with something like KIMTRAC approved, I mean, we have this sort of like playground now where we could say, okay, I'm going to do KIMTRAC for 12 weeks. Then I'm going to send them for liver directed. Then I'll sandwich behind with KIMTRAC, or do your liver directed. You could start to treat your patients like this and say, I'll send them to you first, and then I'll pick up the KIMTRAC.
No, and it would be interesting to know how you guys what your experience has been with that combination. We're seeing some interesting or some good, anecdotally good responses with some flavor of that. Basically, starting KIMTRAC, getting Y90 on board, and continuing KIMTRAC.
Nice.
And it does seem like a potentially exciting combination.
Yeah.
So now that there are more tools in the toolbox, so to speak, let's talk a little bit about symptom management. So when you're doing a systemic therapy and now you're adding in liver-directed therapy, what does that mean for patients in terms of managing symptoms?
I mean, I think it's like Eric said, there's actually not a terrible, liver directed is not going to cause the symptoms. It's typically going to be the drugs. And so the good news is we don't typically have a spike in the amount of symptoms somebody experiences going through the liver directed.
Yeah, I mean, I guess the liver directives are not, it's not as if the patient doesn't experience anything in the way of side effects. I guess we should be, with, I mean, Y90, we generally think about Y90 as a mild therapy, or, and the main side effect, or the thing I tell everyone they're going to feel is they're going to feel tired, and you're going to feel tired for a week to 10 days. And that's universally true. People tell me that I don't get tired. No, I'll be fine. You get tired. Okay. But then, the other things are sort of what I think people kind of come to expect with many of these systemic therapies, maybe a little bit of nausea, low-grade fever, some myalgias, I guess, and then but this is not talking about sort of the risks. Any sort of procedure has its own risks as well, of course, but those don't seem additive, or not. It's not a synergistic worsening of side effects with the local regional therapy and the systemic immune therapies, with the immune therapies. It's just, yes, you have a sort of a set of risks with your procedure, and you have a set of risks with your systemic therapies.
Thank you. We have one more question from our audience, and it is there any evidence of increased immune-mediated liver toxicities in patients who had LDT followed by systemic therapy?
Yeah, and first let me say hi to James out there. It's nice to see
Nice
your
little
name
shout out.
here. Yeah, and it's wonderful to see Courtney's name here, a former colleague at MD Anderson. So that's a really, really good question. The short answer is I think there's not enough data, but there was some anecdotal reports of that percutaneous hepatic perfusion of melphalan. So that system is called the Hepzato system. It's by Delcath, and that percutaneous hepatic perfusion melphalan, this is the one that we were saying is at really selective centers. It's really not scalable to be used at every hospital in the country or the world. There were patients who took that drug or that system, 6 rounds of this percutaneous hepatic perfusion, and then followed it with checkpoint blockade. And there were a couple of striking reports of fulminant liver failure. So this made the community a little bit nervous, but then let's be realistic. After somebody progresses on something like a liver-directed percutaneous hepatic perfusion, an intrahepatic perfusion, Y90, what are we going to give? Of course, we're going to reach for something like checkpoint blockade or Kimtrac. So the truth of the matter is, I don't think that swayed the uveal melanoma providers from saying, well, you just had melphalan and now you're progressing. I don't think I should give you checkpoint. You just have to know you have to monitor them more carefully. There may be something unique specifically about, chemo saturation in the liver and how that might damage hepatocytes that might make you more prone to liver issues after receiving checkpoint blockade. I don't have enough experience, or I don't have an anecdotal count of anybody that's done, say, Y90 followed by checkpoint that's had fulminant liver problems or increased toxicity. I don't know, Eric, if you've had anybody that's had anything like that.
No, I haven't. And, the best, I guess I would say the best data on combination of Y90 and checkpoint inhibition at this point is in not in ocular melanoma, but in HCC, where there actually have been some prospective studies that did not show an increased rate of immune-related liver toxicity, and actually didn't show an increased level of liver toxicity overall in comparison to Y90. And that's a patient community that already has baseline liver dysfunction oftentimes.
Right.
So yeah, it actually appears to be a tolerated combination.
That's really reassuring. And I think, could you do liver directed with something followed by Kimtrac? I guess we don't know, but that will be bound to happen and be reported, and we'll see. Reassuring that in the HCC population, you can do it.
Right. I mean, I should caveat that it's the trial data, these are relatively small trials at this point, but yeah.
Great. Well, I would like to thank both of you so much for participating in our Ask the Expert session during #IGetDilated Awareness Month. Appreciate both of you. We know you are busy with patients and research and teaching and everything else, and we really value your time and expertise. And we would also like to thank TriSalus for generously sponsoring our Ask the Expert series and helping to bring this really valuable education to patients and their loved ones. And again, for anyone who might have missed tonight's live program, this will be available on demand in our on-demand library, and we will be streaming it through our social media channels. And you can see the link there in the chat where all of our webinars are. A lot of really great resources for OM patients and their loved ones through our Elevate platform on our website. So again, thank you so very much. I just wanted to highlight a few things that are coming up this month that are really relevant for our community. Again, November is Eye Health Awareness Month, and it's where we share great information about ocular melanoma resources and education. You can see some of our resources here. Again, our on-demand videos, our Vision Registry, which is our patient-powered, patient-reported registry. Again, encouraging you, if you have not signed up as an ocular melanoma patient, to take part in that registry. We encourage you to do so. We have a lot of great educational literature, free for download, free to send to a physician office. We have an upcoming patient meeting, which I'll chat about in a minute. And we also have an online OM support group. So all of that information is available on our website, melanoma.org. And then we also, if we can go to the next screen there, again, what you can expect this month, a lot going on for our I Get Dilated campaign, which runs through the entire month. We'll be sharing patient testimonials. If you would like to share your story, please contact us. You'll see our contact information at the end. A lot of great blogs and quotes from patients, OM facts, resources, again, sharing our OM patient support group. We also have our Vision annual report, which is the first year of data from our registry, which is available online. Some wonderful community events that are being hosted by advocates. And again, we're going to have another webinar coming up later this month on our Vision registry. So with that, I will just give a plug for our Eyes on a Cure Ocular Melanoma Patient and Caregiver Symposium. The link to register is right in the chat there as well. It's going to be held in conjunction with Moffitt Cancer Center, 3-day event, in person only in Tampa, Florida. A lot of great information for ocular melanoma patients and their loved ones. So again, would encourage you all to join us at that event at the end of March, beginning of April. So again, a big thank you to Dr. Patel and Dr. Warenberg-Klee. Thank you all for joining us this evening. We hope you found the information to be empowering and educational. And again, please feel free to follow us on social media on our OM Twitter and Facebook pages there too, and share photos of getting your eyes dilated this month. We want to see you all out there advocating. So thank you all again. And if you have any questions, you can reach out to education@melanoma.org, and we are happy to answer any questions. So thank you so much and have a wonderful rest of your evening.